My name is Jocelyn. I am a palliative care and movement disorder specialist here at Stanford. That makes me especially glad and honored to be speaking with the MSA community today. This is a group of people truly near and dear to my heart. So when we think about living our best life, I imagine that many of us think of scenes that are similar to those pictured here. Being surrounded by friends and family, enjoying good food, being active, being outdoors, spending time with our children and our parents. Some other things not pictured here might include participating in church and faith communities, caring for loved ones, caring for pets, contributing in our jobs and our work. These are all things that bring joy and meaning to our lives. As a doctor, I see that unfortunately for some people, illness can get in the way of us living our best lives. Illness can create challenges that make it difficult for us to access joy, meaning, and purpose. Those challenges can be physical, they can be psychological, emotional, practical, and even existential and spiritual. I'm here to talk more about how we can recapture some of that quality of life, that joy, connection, and meaning, even when living with a difficult illness. Over the course of the next 20 minutes, we will talk about an approach and medical specialty that we've already talked about that focuses on making life as good as it can be. Along the way, I want to make sure to answer your questions. So if you do happen to have a question, please just raise your hand. But also, I will have a short Q&A afterwards, so we can save those questions for then as well. Today, we will cover the following topics. What is palliative care? How is palliative care different from other parts of medicine? When and how can someone benefit from palliative care? How does palliative care help people live their best life? And the difference between palliative care and hospice. So we can start with the big question. I know Michelle already gave me a good introduction and set me up, but I still think it's nice to start with what is palliative care? What comes to your mind when you hear the word? Go ahead and shout it out. Don't be shy. Comfort. Hospice. Support. Dignity. Near death, end of life. Those are all really great thoughts and components of what makes up palliative care. And I'd like to just start off by talking about what makes palliative care different from other medical specialties. Firstly, in palliative care, we start with the perspective where we center our attention upon the person beyond the disease. We emphasize the individuality of every person we work with. This is our focus. How do we do that? Palliative care takes a holistic approach to someone's care. We think of the people who have the disease and those close to them as the center of that care. That includes their family, their caregivers, their guardians, all of those people included in that central unit. We also acknowledge that when someone is living with a serious illness, that there's more than just the physical symptoms. There's more than just the body that can suffer. We know that the body, mind, spirit, and practical aspects of life can all be affected by illness. Unlike a cardiologist who focuses on the heart, or my work as a neurologist where I focus on the nervous system, we don't just focus on a single organ or an illness. We focus on the person and the aspects of life that are affected. To make sure we address all the components of life that can be affected by a serious illness, like Michelle said, we have an interdisciplinary team. In fact, often you will meet more than one of these individuals during our visits. The doctors and nurses like myself focus on managing bothersome symptoms and prescribing medications. We also help patients and families with medical decisions and advanced healthcare planning. We also help coordinate with the other doctors on your care team. Social workers can provide emotional support through regular phone calls, video visits, or check-ins. They can provide caregiver support to your loved ones, help get medical equipment, talk through financial concerns. Chaplains provide spiritual support. They can offer prayers and blessings, yes, but they also help people face existential concerns, questions that I hear all the time, which is, why is this happening to me? Or how do I make sense of this now that my life looks so different from how I thought it was going to look? Chaplains hold space for those big existential questions, regardless of a person's spiritual or religious background. So far, we've focused on how palliative care is different, and I want to go ahead and provide a commonly accepted definition. I'll start by reading the definition and we can break down each component. Palliative care is specialized healthcare for people living with a serious illness. That type of care is focused on providing relief from the symptoms and the stress of the illness. The goal is to improve quality of life for both the patient and the family. Palliative care is provided by a specially trained team. Palliative care specialists work together with the patient's other doctors to provide an essential layer of support. Palliative care is based on the needs of the patient, not on the prognosis. It is appropriate at any age and any stage in a serious illness and can be delivered alongside curative treatment. One of the first components of this definition is the idea that palliative care is for people living with a serious illness. First off, I would say that any illness that has a reasonable possibility of being life-limiting over a course of years would be appropriate for palliative care. Some examples of illnesses and conditions that I commonly see include cancer, heart failure, multiple system atrophy, atypical Parkinsonian conditions, Parkinson's disease, and ALS. In terms of services that we provide, one of the main ways we can help is to manage any symptoms that are keeping your life from being as good as it can be. Some of the most common symptoms we work with my MSA patients include physical symptoms like pain, difficulty breathing, muscle spasms, increased saliva, as well as some psychological symptoms such as irritability, anxiety, depression, and larger, harder to define problems such as coping, fatigue, and low appetite. So, how do we relieve symptoms? As I mentioned before, we take a holistic or whole person approach, and that applies to managing symptoms. Let's use insomnia or difficulty sleeping as an example. Let's say I'm seeing someone in my clinic who has MSA, and they're telling me their sleep is getting worse. This difficulty sleeping might be related to their sleep apnea, might be related to getting up all the time to use the bathroom, might be related to too much screen time at bedtime. But it might also be related to their increasing worry about their weight loss, might be a side effect of their antidepressant. It might be related to not being able to find a comfortable position due to their back pain. My patient may be so sleepy during the day that they feel more socially isolated from the people close to them. And when they're alone and they're staying up at night, they might begin to wonder, is this a form of punishment for something they've done? Is this a form of punishment from God? To address people's health as a totality, what I actually call total health, we consider what's happening in someone's body and also address how the symptom is affecting their life. So our tools include, yes, medicines, as well as psychological interventions, integrative techniques, and addressing spiritual and existential concerns. In addition to helping manage symptoms, we also help with making medical decisions. This can include things like advanced care planning. We can help people complete documents like advanced directives and post forms. We also help with weighing treatment options. This can include things like helping someone think through whether they want a feeding tube, whether it's time to transition from home to a facility, helping families prioritize what's most important in their loved one's care when time is growing short. As some of you likely know, making medical decisions is hard. Making medical decisions in MSA when there can be so much uncertainty about the future, when multiple people or specialists can have different opinions on what's the next best step, can be even more challenging. This is honestly my favorite part of the job, helping people weigh the benefits and burdens of treatment options within the context of what's important to them. Palliative care is here for you when your healthcare team needs it and when you need it. And that means at any age and at any stage. There's no particular age, diagnosis, prognosis, or treatment plan that makes you eligible or ineligible for palliative care. And it's extremely important to know that we can be helpful anywhere along your journey with MSA. In a typical clinic day, I see patients who have been newly diagnosed, patients who are pursuing treatment, engaged in clinical trials, and patients who are working to live and thrive with their illness when they're not receiving any treatment targeting their underlying illness. Among palliative care circles, a common saying is that if our services were a pill, then we would be the next big blockbuster drug. Part of this comes from the results of a landmark study published in 2010 in the New England Journal of Medicine. The study showed that patients with newly diagnosed advanced lung cancer actually had a survival benefit when they had consistent monthly outpatient palliative care visits. Patients who got palliative care lived an average of 3 months longer than those who did not receive palliative care. Across many studies of patients with many different diagnoses, palliative care has demonstrated consistent benefits, including improved quality of life, symptom control, spiritual well-being, psychological symptoms, satisfaction with care. And many of these studies have also shown that people engaging with palliative care spend less time in the hospital, have fewer hospitalizations, and experience less burden on their caregivers. So this was a question that was brought up earlier, so I'm glad I have the opportunity to ask it, to answer it. Many people wonder when they should ask for a referral and how to get one. I would say if you're living with a serious illness such as MSA, palliative care could be right for you now. We can be helpful if you're having difficulty with symptoms, decisions, or coping. Our team is also particularly helpful if you feel that multiple aspects of life are becoming affected by illness, meaning your mind, your body, and your spirit. Many people wonder if palliative care is expensive and who pays for it. Palliative care is covered by insurance like any other medical specialty that someone is seeing, like your neurologist or an oncologist. Access to palliative care has been improving, and California has started that and helped that in increasing access to palliative care for patients with certain diagnoses who are being covered by public health insurance like Medi-Cal. So how can you access palliative care? The first step is to ask for a referral. You do need a referral to see a palliative care specialist. That referral can come from a primary care provider, a specialist like your neurologist, or an inpatient medical team, or a hospital, or an emergency room. I want to address a very common question that people ask me when they first meet me in clinic. First and foremost, hospice and palliative care are not synonymous, although I will advise you and reassure you that many well-meaning and well-educated healthcare providers will conflate and confuse these terms. So I'm glad you are all here to help me get this correct. As we've described already, palliative care is a large and broad field focused on symptom management and helping make sure the care plans focus on what matters most to patients. Again, we are here for patients of any age at any stage and can be involved in addition to curative treatments. Hospice is a part of that care that palliative care providers are trained in, but it is only a part of what we provide as a field. So hospice care can be a little confusing because the term actually means several things. It's first and foremost a philosophy of care. It's also an insurance benefit. It's also a set of services. So we can break it down a little bit more. As a philosophy of care, hospice focuses on providing patients and with comfort-focused care. So this is supporting people for whom comfort and quality of life are the highest priority. In providing this type of care, hospice typically thinks of every intervention, lab test, and medicine, and they ask the question, does this help this person feel more comfortable? If it does, hospice will try to do that thing and make it happen. If it does not, hospice will recommend stopping that test, medicine, or intervention. Again, the philosophy of hospice is a good fit for people who want quality of life and comfort to be their number one priority. That often includes being less focused on pursuing interventions that might prolong life, but might also prolong the dying process. As a philosophy, hospice also aims to keep people in the place that's most comfortable to them. And for most people, that's at home. So hospice does everything they can to keep people as comfortable as possible while keeping them in the home. And they work to avoid going to the hospital. For some people, being at home is not what's desired, and hospice services can be provided in nursing homes or in other specialized facilities. Hospice as an insurance benefit is a little bit complicated, but it is covered by nearly all insurance plans, including Medicare and Medicaid and Medi-Cal. There are regulations and guidelines that hospices must follow. Medicare provides the guideline that patients must have a 6-month or less estimated prognosis to be eligible to receive hospice benefits. The philosophy of hospice is to provide comfort-focused care. Therefore, hospice may or may not be able to pay for certain treatments that do not provide more comfort. However, there is increasing variability in what certain hospice agencies will cover and allow. So, talking with them individually about individual cases is always helpful. I've seen so many unique situations happen, and because everyone's circumstances are very different. Hospice as a set of services is very comprehensive. This is a busy slide that I won't have time to cover, but we can definitely delve into that more in the Q&A. Hospice agencies are composed, like a palliative care team, of an interdisciplinary team. They can be delivered in the home, in nursing homes, or in specialized facilities like hospice houses. Something I really like to emphasize to people is hospice is not a place. It's more a philosophy than anything else. I'm happy to take other questions about the kind of 24-hour support hotline and their kind of medical equipment and medication support if people have questions for that later. I wanted to at least spend a minute on local resources. And I do know that we have many people joining online from far away. So I do have a link for you as well. We are very lucky here in the Bay Area to have a lot of great palliative care programs. This is a map of some of the palliative care programs who are around in the Bay Area. So you see Kaiser represented, the VA, Sutter, UCSF, and Stanford, and many other hospitals as well. This is certainly not a comprehensive list, but I just put this up to show that we're lucky to have such good coverage in this area with both private, public, and safety net systems. For those joining outside of the Bay Area virtually, the best way to find a palliative care program near you is to visit getpalliativecare.org and search your zip code, or you can always ask your neurologist for a referral. As a take-home message from today, I hope that you will remember that if you feel you are facing a difficult road, palliative care is here to partner with you, your family, and your neurologist to carry the load, to improve your quality of life, and help navigate difficult decisions. I just put up one slide here to describe the Stanford Neuropalliative Clinic, which is a relatively unique resource. The Stanford Neuropalliative Clinic is staffed by myself and my amazing palliative care team. It provides interdisciplinary specialist palliative care for people living with serious neurological disease. We see people virtually and in person, and it's available to all patients in the Stanford healthcare system. Referrals can be placed by any provider within the Stanford healthcare system. That includes your PCP or neurologist. And I put up the details for the palliative medicine referral here. 213 Quarry Road is the Stanford Neuroscience Health Center for people who are familiar with it. It just specifies if you place a referral to Quarry Road, that they'll actually be coming to the Neuro-palliative clinic specifically. And again, if anyone has any other questions about seeing me and seeing my team here in the Neuro-palliative clinic, please talk to me afterwards. Thank you so much for your attention, and we're so blessed to have the sun greet us as we leave today. Take care.
Thank you, Dr. Jiao. That was wonderful. Okay, we have a few questions. Keep the mic on.
Got it.
All right, great. Does palliative care, you said palliative care means no longer treating the underlying disease. You said that, right?
So palliative care can be delivered alongside curative treatment. For example, in my palliative care clinic, I will meet people who have been newly diagnosed with something. They don't even know what their options are. I also work with patients who are receiving very active disease-specific treatment, very active cancer-directed therapy. It can be delivered alongside really any kind of treatment. I also work with people who are not getting treatment. So really the kind of treatment plan you have doesn't really matter. Hospice, in contrast to that, might be a different conversation because the philosophy of hospice is really optimizing comfort and doing comfort-focused care. We really engage in a shift of our focus. We're shifting the goals of that person's care away from, life-prolonging therapies into focusing on how someone is doing in the moment, how someone's doing day to day. So hospice is different from palliative care in that sense. I hope that answers the question.
Okay, great. And similarly, does hospice mean giving up?
A lot of people ask me, and share that when we start to talk about hospice, they ask me, does this mean that I'm giving up? And for me, that always, I love when people ask me that question, because what that is for me is an entryway into really important discussions on what it means to that person to live. What brings them joy? What gives them hope? What are they worried about in their future? What do they think will look different? And what are they, what's really helping them, and also what's bringing them down? So that's my roundabout way of saying that I've worked with so many people who have a serious illness, who are early in their journey. And I've also been there when people have died. And all of those moments have been incredibly meaningful and satisfying for me. And I've seen people live with so much great courage, even in their last moments of life, that I would never say that enrolling with hospice means that you're giving up. So that's my philosophical answer to that.
I think that's a great place to end. Thank you very much, Dr. Jiao.